Today's topic is very much oriented in the clinical perspective. Today we are focusing on radial nerve injuries. We will be looking at the anatomy and later on looking at exact sites where the radial nerve is more or less viable or susceptible for a lesion to occur and to manifest any consequences. And also during this time I will be looking at some of the major issues that we come across in our day-to-day clinical practice and looking at some of the instances where such exemplifications are possible. Now, before looking at the radial nerve as its injuries, I would like to look at the anatomy of the radial nerve, because now if the anatomy is well comprehended, what would happen is that it's much easier to comprehend the lesions and its manifestations. So before starting, I will look at the cause of the radial nerve and its anatomy. So the radial nerve is a nerve that starts from the brachial plexus. Now, as you all know, brachial plexus are composed of the nerve roots from C5 to T1. These are formed within the axilla. In fact, the radial nerve starts from the posterior cord of the brachial plexus. Something that is critically important that you should remember is the posterior cord is composed of nerve roots that are coming from all the roots which from C5 to T1. So the radial nerve has all its roots. Now if there's some sort of a lesion that is concentrated or implied on the nerve root, what would happen is that there is a possibility that there might be weaknesses in the muscles that are being innervated by the uh, radial nerve. So from the posterior cord, it is in close association with two other nerves, which is the axillary nerve as well as the thoracodorsal nerve. The axillary nerve is involved in providing innervation to the deltoid muscle as well as the area of the skin that is present of the shoulder, whereas the thoracodorsal nerve is involved in innervating the latissimus dorsi. So from the posterior cord, it passes to the posterior compartment of the arm. Now it is present behind to that of the radius, to the humerus. So it is present in a particular groove that is present in the posterior aspect of the of the humerus, which is known as the radial groove, or it is given the name radial groove or oblique groove regarding its orientation. So you might ask me how this is possible, because now it has to pass from the axilla into the posterior compartment of the arm. This is possible because traverses past the spaces that are found in the posterior wall of the axilla. Now, if you can remember your anatomy, there are three spaces which are the quadrangular space, the triangular space, and the triangular interval. Now, the radial nerve passes through the triangular interval. The triangular interval is composed of a space that is being the boundaries are formed by the teres major, the humerus, and the triceps. The radial nerve goes out in the posterior compartment with the artery which is known as profunda brachii. So these goes together, profunda brachii artery. So as it passes from the triangular interval now to the posterior compartment, some critical things that you should remember. In the axilla, it provides two nerves, which are nerve endings, nerve branches to the triceps. In fact, the medial and the long head. In addition to that, it also provides nerve branches, a very sensory nerve, which is a nerve that involves in cutaneous innervation, which is known as the posterior cutaneous nerve of the arm, which provides to the posterior aspect of the arm. Now, these nerves are given off at the axilla itself. Now, as it passes through the oblique groove, and then from the oblique groove, it goes into the it comes to the elbow region. At the elbow, it passes through the intermuscular septum and moves into the anterior compartment, but comes back to the posterior compartment of the forearm. Now that's something very trivial, but again should know. So it passes to the posterior compartment of the forearm. Now, as it comes to the posterior compartment of the forearm, what would happen is that it branches off to give posterior interosseous nerve, which provides innervation to all the extensor muscles of the wrist and the joints that are present in the finger. So what it does is that it involves in extension of the wrist joint and the extension of the fingers. Right. So from the posterior compartment, there's the posterior interosseous nerve, and the other branch would be the superficial branch. A superficial branch is a sensory only nerve, which means that it can only do sensory innervation. It passes more or less in a superficial manner, goes through the anatomical snuff box, and find its way anatomical snuff box and find its way to the dorsum of the hand, providing sensory innervation to the particular area. Dorsum of the hand. Right. Few things more. So it passes from the posterior compartment of the arm to the posterior compartment of the forearm. At the forearm, it divides to form the posterior interosseous nerve, which is a nerve that is involved in muscular movements, extension of the wrist and the extension of the fingers, and it provides a superficial branch which provides innervation to the dorsum of the hand. Now, in addition to these, you should also know that it gives off more or less in the distal part of the arm. What it does is that it gives off two other branches, one present slightly in a more proximal manner, which is known as the cutaneous nerve of the lateral arm. This provides innervation to the lateral as lower. It's given the term lower as well. So it provides innervation to the lower aspect of the lower lateral aspect of the radial nerve. So the lower lateral aspect of the radial nerve. Now I was speaking about as the nerve passed from the posterior compartment of the arm to the posterior compartment of the forearm. In addition to this, there's another cutaneous nerve which is given the name posterior cutaneous nerve of the forearm. As the name implies, it provides innervation to the posterior aspect of the forearm. So there now you have come across four cutaneous nerve. One was the posterior cutaneous nerve of the arm, then the forearm, then the lateral aspect of the lateral aspect of the shoulder, lower lateral in fact, and then there was the superficial nerve providing to the dorsum of the hand. Now one thing that is very significant is that now as it passes via the elbow joint up to the posterior compartment of the forearm, it provides innervation to the extensor carpi radialis longus. Again, something very trivial, but you tend to see certain difference in individuals who are presenting with radial nerve lesions. So, extensor carpi radialis longus, which is also capable of extending the wrist joint. So from the posterior compartment of the forearm, it gives off the posterior interosseous nerve, which does the extension of the wrist as well as the fingers. And also it gives the superficial branch, which is involved in innervation of the dorsum of the hand, which is sensory. Now what would happen is that if there's a fracture at the oblique groove of the humerus, a midshaft fracture, all the latter aspects would be disrupted. But since it provides innervation to the triceps, particularly the medial as well as the long head, at the axilla itself, the work of the triceps is unaltered, or it does not have any sort of a change. So therefore, the individual can extend the arm and also involving extension of the elbow joint as well, because the triceps are functioning, but will have problems in extension of the wrist as well as the fingers. So you would see the presence of a wrist drop as well as a finger drop. So in summary of the radial nerve at the axilla gives off nerves to the tricep and also to the posterior cutaneous nerve of the arm. Then at the oblique groove, it is above the oblique groove, there is a nerve to the triceps, and below to the oblique groove, there is the nerve that is given to the extensor carpi radialis longus, plus the posterior cutaneous nerve of the forearm and the lower lateral cutaneous nerve of the arm. Then this is at the oblique groove. Then it divides, which is the posterior interosseous nerve and the superficial branch. So this is how it goes. Superficial branch is sensory, whereas the posterior interosseous nerve is involved in extension of the wrist and fingers. So where are the possible lesions? Now if you know, first of all, there could be lesions happening in the axilla. If you can remember, there is this instance where people who are drunk rest in a way that there is impingement of the nerve at the axilla. Now this is called Saturday night palsy. So what would happen? The nerve is compressed at the axilla itself. Now this is even seen in people who are walking with clutches. So what would happen is that the head of the clutches would be impacting on the axilla, compromising the nerve or causing compression of the nerve. So in Saturday night palsy as well as clutches, you would see that the nerve is compressed at the axilla itself. So what would you lose? You would lose everything. The patient will not be able to extend the elbow joint, the shoulder, elbow joint particularly, because the triceps are not working. There will be cutaneous loss in all the areas which are provided by the radial nerve. And also there will be a wrist drop as well as a finger drop. Why a wrist drop? Because the wrist is maintained at its normal position because of the action of both flexors as well as extensors. They are working in harmony. So what would happen once the radial nerve is in sort of a not in a suboptimal way, it's not working. What would happen is that the extensors are not working. Hence, the wrist will move towards the flexion in a more or less a flex version. So you would appreciate that the patient has a sort of a drop at the wrist, which is given the term wrist drop. So even fingers will have the same problem because of the malfunctioning of the extensor carpi, extensor digitorum. So overall, all the manifestations will be possible. But if there is a fracture, a mid-shaft fracture of the humerus, a mid-shaft fracture of the humerus, you would see that the triceps are spared because the nerves that are provided to the triceps comes from the axilla itself. So therefore, in this case, the triceps are spared, but there will be wrist drop. And also, more apart from the posterior cutaneous nerve of the arm, all the other areas which are innervated by the radial nerve will have loss of sensory function. Now, the other possible area where there will be there are multiple other locations where the radial nerve might undergo lesions, but these are the most common positions. Now, one thing would be the Saturday night palsy or the clutches at the axilla. Then there's the midshaft of the humerus, a fracture of the midshaft of the humerus, particularly at the oblique groove. Then sometimes, as it passes, the posterior interosseous nerve passes between the two heads of the supinator. Due to the presence of few bands, what should happen is that the posterior interosseous nerve may be compressed. There will be a neuropraxia, which means that the nerve is compressed and it's not functioning. Neuropraxia of the posterior interosseous nerve. So in this case, what would happen is that all the muscles that are innervated by the posterior interosseous nerve will not function. Therefore, these muscles which are involved in wrist extension and the finger extension are lost. Therefore, you will appreciate the presence of both wrist drop as well as a finger drop. But there's a catch. Before branching out, it provides a nerve branch to the extensor carpi radialis longus, which is also involved in wrist extension. Therefore, the wrist extension will not be very prominent. Given in other terms, the patient will not show a flex position in the wrist. But of course, since the extensor digitorum are not working, the tendons to the fingers are not working, there will be finger drop but not the wrist drop. So in this case, you would appreciate the presence of a wrist drop but not a finger drop but not a wrist drop. This is the difference. And there will be no sensory loss whatsoever because both the superficial branch as well as the other nerves that are providing innervation to the arm as well as the forearm are spared. Therefore, no sensory loss. So these, in addition to this, there is another other location as well, which is present at the posterior wall of the axilla at the triangular space, triangular interval. At the triangular interval, again, there is a possibility that due to the formation of certain muscular bands or the muscle hypertrophy, sometimes there is a possibility it might show compressions to the radial nerve, as well as in this case what would happen is that the profunda brachii artery is also compromised. There will be ischemic changes as well, but it is not very significant because this happens gradually over time and there will be collateral formations. However, once this happens at the triangular interval, the manifestations are quite similar to that of um, a lesion that is happening at the mid shaft of the humerus, such as a fracture of the humerus. So, uh, in this case, you would appreciate the presence of a wrist drop, a finger drop, and as well as the sensory loss in the posterior cutaneous nerve of the arm as well as the lateral cutaneous nerve of the arm. However, the extensors will be spared. Extensors, which are the triceps, will be spared. In addition to this, there is a possibility that there might be a lesion or a cut at the anatomical snuff box. Now, most of the time, what would happen is that since this is very superficial, there might be traumatic injury, a cut injury where the superficial nerve of the radial nerve might be disrupted, and therefore the patient, there will be no motor dysfunctioning. However, what he would sense is the loss of sensation in the dorsum of the hand. And also something in addition to that, I would like to say is that if such an injury happens, now there are multiple methodologies where such injuries can be repaired. Usually this is done by the uh, people who are engaged with plastic surgery. What they do is that there is suturing of the nerve, as well as they allow the shown cells to reform and cause reformation of the nerve, and it will be functioning back again, and the innervations will be re-established. So these are few uh, lesions that you would see in the radial nerve. Now, in addition to that, something other than this, now as I said, the radial nerve is coming from the posterior cord. It consists of nerve roots from C5 to T1. If there's some sort of a nerve root compression, there is a possibility that the individual might show weaknesses of the muscles that are being provided by the radial nerve. This includes the triceps, the extensor muscles of the forearm, as well as the extensor muscles of the fingers. Uh, there also will be tingling as well as paresthesia, abnormal sensation in the aspects that are being innervated by the radial nerve. So one way is nerve root compression. In addition to this, there is also, this is usually another term that we can use but not interchangeably, is the radiculopathy. So in radiculopathy, there is the root compression, and the most problems are in a particular root rather than the whole nerve itself, because the nerve is composed of many multiple roots. If for an instance C6 is compressed, what would happen is the manifestations are particularly in the nerve fibers that are being, or the motor fibers that are being innervated by C6. Now for an example, extension of the elbow is done by the triceps. The triceps are innervated by C6, C7 and C8, and extension of the fingers is done by C7 and C8. So if there's some sort of a lesion in the C6, what would happen is that there will be manifestations or weakness in the elbow extension, but there won't be any problems with the finger extension. So it is something of that sort. And the other lesion that we would like to consider is the posterior cord plexopathy. Here, what has happened is that in this case, the posterior cord is compressed and compromised. Therefore, with the radial nerve, the other nerves that are in association will be impacted as well. For an example, the posterior cord gives rise to both the axial nerve as well as the thoracodorsal nerve. So there will be weaknesses in the shoulder muscles, the deltoid, and also the latissimus dorsi, the back muscle. Hence, you can come into a conclusion by testing all these muscles. You can come to a conclusion that it is a plexopathy uh, rather than a radiculopathy, or rather than a lesion in the radial nerve itself. Usually, the investigation of choice is the nerve conduction study, where we would like to see how the neuron stimuli is conducted in a the velocity of the neurons conducted in a terminal nerve. By assessing this, we can come to a conclusion how the radial nerve is functioning, if there's any sort of a lesion that is been uh, associated with the particular nerve. So this is how it happens. Now there are sometimes even strokes that would lead to the manifestation of wrist drops, but in this case, usually it is unilateral, and we would appreciate that there will be other signs as well, which includes the now if this is involved with the location of the stroke as well, so there will be other manifestations such as the loss of pupil reflexes, problems with GCS, reduction of consciousness, urinary incontinence, and so on. So most of the time there will be dysfunctionalities of the cerebral cortex. Hence, such manifestations are present as well. In addition to this, we would sometimes people presents with, this is not quite common, it's very rare, but sometimes patients come presents with bilateral wrist drops. Now, bilateral wrist drop is not something that we can attribute to any trauma or any uh, mechanical injury, because it's not very possible. In these cases, we have to think about peripheral neuropathies. Now this something more common is the presence of bilateral foot drops rather than wrist drops. However, again, there has been uh, there has been case studies which has been published, which has attributed peripheral neuropathies that have been leading to bilateral wrist drops. So these are few things that you would like to appreciate in circumstances where radial nerve lesion has happened. So before concluding this, I would also say about a condition, because this the superficial nerve that comes at the latter end is very superficial, so that by using sometimes tight bands, rings, not rings, bangles, or any other of that particular sort, what would happen is there is a possibility the superficial nerve might be compressed, and therefore the patient will uh, complain of a tingling or a paresthesia, particularly in the dorsum of the hand. Hence, you should know this is because of nerve compression, and it is because of the fact that the superficial nerve lies very close to that of the skin, and you have this is known as the Wartenberg syndrome. Something extra for your knowledge, but still it's another possibility. So I have related almost most of the lesions that are associated with the radial nerve, and also have illustrated some of the other factors that might lead to manifestations which are close in description to that of a terminal nerve lesion. So with this I have concluded, I am going to conclude my discussion about the radial nerve injuries. So in the next upcoming videos I will be talking about ulnar nerve as well as the median nerve as well, in regards to that of the clinical anatomy of upper limb.